Good morning, everyone. Hi from ACA. My name is Jamie Harley, and I am the new HIT Outreach Coordinator for the agency. Today's educational session is a deeper discussion on untangling HIE and a better understanding of the Encounter Notification System, or ENS. Our guest today is the Florida HIE Director of Point Click Care, or PCC, Brian Smart. Please welcome him as our subject matter expert. Please also remember that you are muted until the end of the presentation. Please put any questions in the GoToWebinar, the question pane. I have Pam and Meredith with me, both monitoring for your questions, so we can make sure we answer all of them at the end of the session. So with that, Brian, here you go.
Thank you. Thank you very much, Jamie. Hopefully everyone can hear me all right. I really appreciate everyone taking some time today. Jamie and I have been working on this presentation for a little while. I'm really excited to talk about the Florida HIE's ENS service, which is Encounter Notification Service. I think if you can move to the next slide. Yep, one more after that, and here we go. We're getting started. So I think just to level set for everyone on the Florida HIE, one thing to note about it is the Florida HIE is an ADT data exchange. It's not a CCD repository. We don't store any data. We don't have a query model or anything like that. It's basically a way for admit, discharge, and transfer data to flow out of the connected facilities under the Florida HIE into subscribers. And these subscribers can be virtually health plans, ACOs, provider groups, skilled nursing facilities, and of course, hospitals as well. We are officially operated and under contract with the Agency for Healthcare Administration, ACA. The Florida HIE was founded by the state in 2011. And the goal is to provide statewide ADT data for healthcare providers to improve care coordination across the state. This can be Medicare and Medicaid and commercial patients as well. This isn't just a Medicaid thing. This can be really anyone that an entity would like to subscribe to and monitor the treatment of that patient post-discharge from one of these facilities. One thing to note, Point Click Care is essentially the technology vendor behind the Florida HIE. We operate the infrastructure, we operate the MPI and the data flow, but ACA governs the relationship. They establish policies, they have convenient stakeholders to get together and determine policies, next steps, where the HIE is moving and what the framework's going to look like. We're just the technology vendor, but I think we reach out to a lot of our subscribing entities to understand what additional capabilities and functionality we can bring to the Florida HIE to improve the flow of ADT data. We're not looking to just stand something up and say, here's the data we're doing and here's how it's going to look. We want to really get input from our subscribers, and we take that information back to ACA, and then ACA determines if that's something we want to do and improvements we want to make to the Florida HIE framework. So, next slide. So I think we move into the next slide. What we're really looking to focus in on is the Encounter Notification Service, which is the main service the Florida HIE provides. And ENS is short for Encounter Notification Service. And basically the way it works is we can notify a subscribing organization in real time or once a day if one of your patients that you say are attributed to you, you either have a direct treatment relationship with them, you've obtained consent with that patient, and you allow for your patients to be monitored. So what happens is you provide us a list of patients that you want us to track and monitor, and then when one of those patients has an encounter at one of our connected facilities, we send you data back. Now, this data can be used in a lot of different ways, which we're going to talk about moving forward here in this session. But I think a couple things to highlight. Post-discharge follow-up for TCM, that's a huge thing that a lot of our provider entities really like, especially in the Medicare space. You know, when a patient gets discharged from an ER, the ability to call them after that TCM and get them in for a follow-up visit, ADTs are the way to do that. Otherwise, you really don't have a direct understanding that your patient walked into an ER facility in either an inpatient or ER setting and had an encounter. And ADTs allow that data from the Florida HIE to flow directly to you, and you get alerted that, hey, one of my patients just walked into an ER. The other thing is when you see a patient was admitted to a facility, maybe you as an entity want to call into that hospital and say, hey, this is my patient. I just want to let you know they have XYZ condition, or I just prescribed them a net new prescription last week. Maybe this encounter has something to do with that. And it also allows a potentially avoidable readmission. We have a lot of subscribers that say, I had no idea that my patients were going into the ER for a flu shot, or they were going into the ER because they cut their finger, but it's because maybe that patient didn't know you as a provider were open past 6 o'clock. They thought you closed at 6 o'clock every day. So it really lets you let your patients know that, hey, you don't need to go to that ER for that particular thing. There's an urgent care right down the road, or I'm open till 9 o'clock, or I have an on-call. You can call my office, and if it's an emergency, we can come and see you. So understanding that your patient had a potentially avoidable hospital encounter is the first step to avoid readmissions, them going to the hospital over and over again. The other thing is, some patients continuously go into the ER for all kinds of things. It may be asthma, a behavioral health situation, a social determinant of health situation. Maybe it's someone who just can't have or doesn't have transportation to pick up their prescriptions, and they're not taking their prescriptions regularly. The ability to understand that that patient had an encounter and why they had the encounter through a diagnosis or a patient complaint information that you receive allows your organization maybe to put them in a particular care program that will allow you to understand this patient is in our behavioral health or a social determinants of health care program, or this patient has COPD or asthma, and we want to put them in a program to treat their specific ailment to avoid them going to the ER for something that we just need to be aware of, and we can provide them the proper treatment. You know, maybe it's Meals on Wheels, or provide them a prescription delivery program. Little things like this that when you're aware that your patient has this issue, you as an entity, whether it be a provider or an ACO or even health plan, you can tell them, hey, now that I know you have this particular issue, let me subscribe you to this particular program that's going to prevent this issue from occurring over and over again. So hopefully with this What is ENS, you guys can see that ENS allows real-time ADT data to flow to a subscribing entity based on a patient panel that you submit to us. And that some of the use cases of this data coming back to you highlighted here that I think really show the benefit of this data. Because ADT data coming back to you shouldn't be used just for one thing. It can be used for all different kinds of things. And hopefully the 4 things we listed out here is just to start to where your head's starting spinning now, thinking, whoa, look at all the things I could use this ADT data for and how it's going to benefit my patient and my treatment of the patients throughout the entire care continuum. Next slide, please. So as I mentioned before, there are 4 benefits that we want to highlight, but a couple of things that I think are really important to you as an organization. Reducing the readmissions and the length of stay, increase revenue to your organization from a TCM standpoint and cost savings, especially if you're in a value-based contract. Preventing them going to the ER for unnecessary admissions is a really increased revenue and cost savings to your organization. Patient engagement and satisfaction. I mean, imagine if you're a patient, you're in the ER and you just got discharged, and your physician, who you've known for 5 years, calls you out of the blue, just wants to check in on you to see how you're doing. Like, that makes a patient feel really good and makes them know that, hey, my provider really has a good understanding of what's happening with me, even when I'm not inside his 4 walls. The improvement of quality of care and outcome. The idea that if a patient leaves a hospital and maybe they need a rehab or they need a skilled nursing facility, you as a provider or you as an ACO being aware of that, their admission, or maybe making sure that they get transferred appropriately into that, it allows that quality of care and the patient's outcome to improve exponentially across their entire treatment. And then also it helps you as a provider group to understand what other providers potentially are involved. I mean, you know, if they go in an ER and they get admitted, maybe they transfer up to radiology. Maybe they go somewhere in the hospital that you were like, whoa, they went to radiology, or they went to some other department in the ER. Maybe it was a behavioral health instance where they came in for a behavioral health treatment. This is stuff that you as a provider subscribing entity can understand. What other entities are they seeing within the Florida HIE? Because the Florida HIE doesn't just provide acute care encounters. It does post-acute, it does rehab, it does home health, it does hospice, it even does EMS. So if a patient calls an ambulance and declines to be transported to the hospital, that EMS alert is going to come to you, and you can know, why did this patient call an ambulance but decline to go to the hospital? Another unique thing about the Florida HIE is we actually have urgent care facilities connected as well. So if the patient doesn't go to an acute setting, but maybe they go to an urgent care, that's something you can get alerted on and understood that, hey, my patient went to urgent care at 3 o'clock in the afternoon. Why didn't they come see me as a provider? And ACOs might want to know that as well, especially if they're in a value-based risk contract. So these are some of the basic benefits of it. But again, I think patient engagement and satisfaction to me is one of the key things, and improvement of quality care. I know the revenue and cost savings is something on everyone's top of mind, but the idea that you can improve the quality of care for a patient and you're engaged with that patient and really have a good understanding of where they're going in the healthcare space throughout the state of Florida, to me is a really beneficial thing, and it just makes the patient feel valued, which to me is a key thing in this busy world that we live in with a lot going on. The idea that a patient is being valued by their healthcare providers is a really good benefit of the Florida HIE and the ENS service. Next slide. So this is where we're going to get into a little technical, and if people want to zone out or put me on mute, feel free. But I want to just let everyone know how the Florida HIE ENS service operates. There are 3 pillars of this particular infrastructure. The main pillar starts on the far left of your screen. It's number 1, the data sources. The service is only as good as the data coming in, because the data being pumped out isn't beneficial if it's missing a lot of things. We provide an analysis on all our data sources that get connected to make sure they're contributing data in the way we want it to be. We'd like it to be timely. We'd like it to be complete with the patient demographic information, and also really quality data. You know, diagnosis code, discharge disposition, patient admit, attending physician, admit time, discharge time, patient class, event type, all this type of stuff. We want to make sure our data sources are sending inbound to ENS. So when that inbound, that ENS wheel starts spinning, it's able to match a patient to your roster because the demographics that were provided by the data sender are correct. It's when that data starts to match and then we pipe it over to the subscriber, that quality of the data is beneficial. One element of this that really kicks things off is on the right side. If you as a subscribing entity are providing us bad patient demographic, the better data we get on the data sender side isn't going to help the bad data you as a subscriber are providing us. If you have Medicaid population that just is a really transient population and doesn't have quality demographics, it's going to be really hard for us to match that quality data coming in with the subscribers' bad data coming in. And that's when the ENS wheels go off the rails. They don't start matching. You're going to miss alerts, and data isn't as quality as you'd like it to be. When subscribers provide us quality data on their patients and they give it to us at a regular basis, either weekly, monthly, even quarterly, we get that quality updated data with updated demographics, updated phone numbers, updated street addresses, all that information coming into ENS, those wheels really stay on the track, and we're able to do a really good match rate. You know, our match rate is upward 90% when we have good quality data coming in from both sides of the house, data senders and subscribers. And what happens is when you provide us a patient list, the subscriber sends it into ENS, the data sources send it into ENS, and then we match. And we match that based on a myriad of solutions. We have an IBM MDM system that matches on demographics. It also stores historical patient information as well, not only from the data source side, but also the subscriber side. So if you've got 5 addresses that you provided us over the last 5 months for a patient, the data sender might send us an address that was used 3 months ago. Our MDM system matches that up and says, that date of birth is right, the first and last name is right, the address is off, but I have that address from 3 months ago. I'm going to go ahead and create a match, and I'm going to alert the subscriber. And that's when we send data back to you. However, you as a subscribing entity has requested that data to come back. It can be in all different formats and frequencies. We have real-time data. Literally within 10 minutes from that encounter occurring, we're sending you that data. It can be daily. If you say I only want to receive daily files with all the encounters that have occurred in the previous 24 hours, we can accommodate that as well. But again, the main thing about this is quality data coming in from both sides of the house mean that ENS wheel in the middle is spinning right, and it's going to send the quality alerts back to our subscribing entities, and better demographics and better quality data from data senders are really what makes this whole thing work. And we've had great success. I think if we move to the next slide, that's where I'm going to highlight the connectivity we have and the real
Hey,
benefit.
Ryan, can I
You know,
jump in and ask a question real quick?
yeah, of course, Jane.
Can you, while we're on that slide, can you kind of explain on a provider side how they use the Florida HIE data that is being collected?
Yeah, so I think that you're referencing when maybe data comes in from a data center on a patient that they don't have, or maybe it's been updated. If I'm hearing your question right, we have a lot of providers who say, I think I have the right address. I mean, last time I spoke to them, this is the information they had. And they might get different demographics from the data center because the hospital at the time of admission acquired or obtained different demographics of the patient attested to at the time of the encounter. So real benefit there is you might get the first and last name, you might get the date of birth, but you may get a different address, or you may get an updated telephone number that you as a provider who has a direct treatment relation to this patient don't have, because maybe they got a new cell phone or maybe they moved to a different apartment. And this is really beneficial for you as a provider to understand that I'm getting the latest and greatest demographics from the patient directly when they had an encounter at a hospital. And that allows better outreach, better communication with the patient, and it allows you as a provider to keep your records updated and keep all the demographics of the patient as accurate as possible. Jamie, was that kind of what you were thinking about in the wheelhouse there?
Exactly.
Yeah,
Perfect. Thank you.
great, great. So as I was talking about, the quality of data coming in, the Florida HIE and ACA has done an incredible job with. There are standards that are necessary in order for a data center to contribute data. There's also requirements out there where acute facilities have to connect to the Florida HIE under the low income pool funding. And what that means is Florida HIE is probably one of the most robust HIEs you'll see in the entire country. We have nearly 98% of all the acute care hospital beds covered. Every single major hospital system outside of Mayo is connected and providing data to the state. Mayo is signed, and we're looking to get them active here in the next couple weeks or month. But every other, Orlando, Memorial, Naples, everyone from Advent all the way down, Tallahassee, you name it, HCA, all connected, contributing real-time ADT data to the Florida HIE. We also have about 90% of all the rehab hospitals connected and contributing data. We have over a little bit under 200, maybe a little over 200 individual skilled nursing facility data is flowing into the network. This includes organizations as large as Palm Garden, Southern Healthcare Management. All these large skilled nursing facilities are contributing data into the Florida HIE. We have home health and hospice providers as well, individual home health entities, and then hospital-owned home health entities, like Parish Home Health is connected. Behavioral health facilities. This is something ACA has done a great job with. We've really appreciated their support in getting crisis stabilization units connected and contributing data. We have Aspire is a big crisis stabilization unit contributing data. Meridian Health is another one that's contributing data. And that allows our subscribers to know when one of their patients checks into a crisis stabilization unit for treatment. And it just allows them to be a little more abreast of the entire care continuum, not just acute encounters, but also a crisis stabilization unit encounter. And then I talked earlier about the EMS treat and release. This is really unique. There's only a few states in the country that are doing this. And the Florida HIE really spearheaded this, and they did a great job working with Department of Health to ensure that all 67 counties EMS organizations are connected and contributing data. So when a patient calls an ambulance but declines to be transported to the hospital, you're going to receive that alert, and you're going to be alerted that, hey, my patient called an EMS, declined to go to the hospital, and I got that alert. It's real-time data. That's the other key thing here. It's not delayed. It's real-time. It's going to come to you. If you want it in real time, you're going to get it in real time. There is a public, which is another unique thing about this Florida HIE, though. There is a public URL, which listed here, that you can go on and see every single connected data center and every single connected subscriber as well who's receiving that data. So not only if you're on this call and you're a data center and you're wondering, is it beneficial for me to connect as a subscribing entity? It is, because now you can see all the organizations that are receiving that data that you're contributing to. If you are a subscriber and you want to know, hey, I'm located in the Panhandle, or I'm located in Tampa, I want to know facilities are connected in my city. You can log on, you can download it, and you can see every single facility in a particular county, in a particular city, who is connected, and make sure that they are contributing data. If they are not, you can reach out to us directly, and we will reach out to them and try to get them to connect. If you have a if you have a referral relationship with them, and you want to make sure they're connected because you're subscribing to Florida HIE, and you said, hey, I'm not going to refer any patients to your organization unless you start to get connected, you can go ahead and send us that information, put us in contact with them, and we'll go ahead and get them connected. It doesn't take a long time, and it's no cost to a data sender to contribute data to the Florida HIE. Next slide there. So as I talked to previously about some of the subscribers, this is just a high-level list of organizations that are subscribed. Pretty much every single health plan in the state, minus Cigna, is subscribed. Almost all the ACOs in the state are subscribed, and we also have a lot of health systems that are subscribing as well, and over 188 ambulatory organizations are subscribed. These are small ambulatory with 3 or 4 docs with a couple thousand patients, all the way up to the large pediatric associates, the Chin Meds, the Optum Cares, the really big ambulatory providers that are connected as well and receiving this data. So my point being in that is a lot of different types are seeing benefit in this. It isn't the big guys, it isn't the small guys, it isn't just ACOs, it isn't health plans. All organizations really see value in this ENS data, and they see buy-in, and they really want it because they see value in it. The Florida coverage, 18 million total lives covered in Florida, and we as a technical vendor send about 8.5 million notifications a month out to all the different subscribers that are subscribed to the Florida HIE. Next slide here. Jamie, I wanted to check in how I'm doing on time and if there are any questions to this point.
We're doing fine on time. Can you go in a little bit more on, how Florida took a more robust approach to HIE? Can you kind of explain how we're a little different than some other states?
Yeah, that's a great question. And it kind of relates to a little bit about, some of the use cases that we saw from our subscribers. But, specifically when HIEs, I think, were first getting started, a decade or two ago, excuse me, they took the approach of, okay, we're going to stay state siloed. We're going to host all the data, keep all the data, CCD repository. We're going to do it all. We're going to do everything. And I think that some HIEs realized that that was a lot for them to bite off. It was a lot of data costs, infrastructure costs, and a lot to manage it and mandate, frankly. And the Florida HIE, with ACA's great vision, they decided, you know what, instead of being a query-based model, why don't we lean in and take a look at just exchanging ADT data? It's simple, it's cleaner, it's much more configurable, and it really runs the gamut of, do you want a flat CSV file sent to your email every day, or do you want a real-time HL7 integrated into an Epic EMR system? It runs everything in between. And that was the great approach by ACA and their vision to say, instead of us trying to do a little bit of everything, why don't we really focus in on ADT data exchange and be really good at it? And by good, we mean have one of the best patient matching indexes in the country, have one of the greatest and highest level of connectivity in the country by acute care, skilled nursing facilities, post-acute, things like that. Really focus in on those and make sure that we're the best. Instead of trying to do a query model and exchange ADTs and run a direct messaging system and all these other things, let's focus in on exchanging ADT data, have really good quality data coming in, and then make sure that the way our customers want to receive that ADT data back, we make it really easy for them to ingest it. It doesn't have to be this way. It doesn't have to be that way. And I think the Florida HIE has done a great job of making sure that if a customer comes to us that is really big or really small and they have a specific request, we typically have done it before and we can do it now. The best ADT data coming in from acute facilities, the connectivity is, like I said, 98%. And then we can send data back to you, again, in that flat CSV Excel spreadsheet, or we can send it into an HL7 real time into an Epic EMR system, or a Cerner, or Athena, or ECW, whatever it might be. Everything is different, every customer is different, and I think ACA really wanted us to perfect that, and that's what we've done, and we've done a great job with that, I think, from our connectivity and then the number of subscribers we have as well. So I think moving on here, I wanted to take some time and just highlight. I know I've mentioned it in previous conversations, but I want to really look at the type of data you can expect to receive within an ENS alert. Um, Obviously, patient demographics is something we mentioned before, and I think Jamie's question really alluded to the fact that you're getting updated patient demographics from the time of the encounter. Typically, they come directly from the patient. They hand photo ID over, or insurance card, or the admitting physician might ask them specifically what's your current address, what's your phone number, things like that. The originating facility. This is another key factor. The Florida HIE did a really good job of labeling the facilities and also the type of facility. So if it's a home health, you're going to see in the title it says home health. If it's a skilled nursing facility, you're going to see in the title SNF, skilled nursing facility. If it's hospice, if it's a rehab, if it's EMS, you're going to see all that in the facility name to give you a real clear understanding of this is the facility that my patient had an encounter at. The admit discharge timestamp, obviously that's important. The patient class. So we report on emergency, inpatient, and observation alerts as well. So all this data can be provided to you based on the different type of patient class, but you can expect to get an emergency, inpatient, and outpatient encounter. The attending physician, patient complaint is another unique thing. Most HIEs provide patient complaint, but what we've really seen is the diagnosis information. The patient complaint may come in with a headache or a broken leg, but then under the diagnosis information, we provide multiple diagnoses. So not just the primary, the second, third, fourth, and fifth. So the patient complaint may be a broken leg or pain in their ankle. The diagnosis code may be a broken leg or broken ankle, but maybe the second or third diagnosis was, alcohol or, opioid substance abuse, things like that. That really could help a subscriber say, okay, well now this isn't just a broken leg. This is a potential encounter around opioid overdose or alcoholism or different sort of behavioral health or social determinants of health or something like that occurred that maybe was a result of it. And that's something that we really are happy about, that we can provide multiple diagnosis information back, not just the primary. The hospital service is something that's provided as well. It's typically coded, so it isn't overly beneficial, but we've got code maps that can tell you what the hospital says this code particularly means. The discharge disposition and discharge to location is a really beneficial thing that I'm very glad the Florida HIE can provide. And the death indicator. This obviously isn't populated often, but it is sometimes, and it's beneficial to know that this patient expired during this encounter, and that's denoted through a death indicator that we can provide at the Florida HIE. Let's move on to the next slide. Unless, Jamie, there are any questions with anything? All right.
There are a few questions, but I'll save them till the end.
Okay, great. Notification delivery. This is something that I just wanted to run through really quickly for folks. I don't want to get into many details because obviously everybody is different. The way they want to receive alerts is different. But as I was talking about before, the Florida HIE has made a big initiative to make sure we can meet everyone where they want to get the data. We have a proprietary care coordination portal called ENS Prompt. It is a lightweight care coordination tool that allows real-time data to flow into this portal. It's easy to access. Any user can have access to it. You can filter, you can search for diagnosis information, patient name, facility, all kinds of things in it. And I'm happy to provide a link to a video on the Florida HIE website that provides some tutorials on that. But again, it's just a way that we can send ADT data into this prompt portal, and the Florida HIE runs and manages that portal. And there's also no additional cost for it too if a subscriber wants to receive it. We can send direct messaging and email alerts. So email alerts can't contain PHI, but it can alert you that a patient had an encounter at a particular facility, and then you can log into an SFTP site or your direct messaging service to see the actual PHI on that encounter. We also offer FHIR and HL7 integrations as well. As I mentioned, direct messaging. The Florida HIE has a HISP by the name of Impriva that offers direct messaging accounts if you want to pay them for it. But you can also have a direct messaging account through EMR, and we'll send data to your direct messaging address. And then I mentioned again a lot, CSV. It's a flat Excel spreadsheet that comes right to an SFTP site. You can open it up and it looks just like an Excel spreadsheet. You can apply filters and all the things you can do in Excel, but that's another format that we can deliver in. So I think next slide. The last thing I want to touch on here is our smart alerts. And I don't want to go into too many details about this, but it is something that some of our health plans and providers have adopted because they see the benefit in it. If you're a provider group and you are subscribed to 10,000 patients, and you've got patients that are on Medicare and Medicaid and 10 years old and 90 years old, there's going to be a lot of alerts coming in for a lot of different things. And maybe understanding that a 10-year-old went to an ER for a broken arm isn't as important as a 90-year-old went into the ER for a heart attack. But you don't know that because you're getting the alerts in a flat file and there's 70 alerts on it and you get it every day. And you have to go through every single 70 alert to figure out which alert is the one I want to focus in on today, and which is the patient that I need to call maybe for a follow-up appointment, or I need to call the hospital on admission to let them know that this has been my patient for 50 years. They are prescribed to these prescriptions and they recently had a heart attack, 6 months ago. So what we can do for your organization is set up something called smart alerts. And the unique thing about that is smart alerts can be curated for specific diagnoses, patient criteria, or level of interest. If you say we are a provider group that have a severe number of Medicaid patients, and we really want to look into social determinants of health, patients that are homeless or patients that are having issues around social determinants of health, and we want to get alerts on them, but we want it sent to a specific person within our organization. We can set up that particular alert. So if a patient has a social determinants of health alert in the ER, we send that alert to another, person within the organization. If there is someone who's focused on maternal health or asthma, or your organization that wants to focus on HEDIS measures or behavioral health or COPD, whatever it might be, you can tell us to set up these alerts. You can set the criteria. It can be age, it can be facility, it can be diagnosis codes or descriptions, whatever it might be. And we'll set these smart alerts up. And then if a patient has an encounter that meets one of those criteria, we can alert you to another location, or another person can make sure they get those alerts and they start working on those. Because maybe they're in the maternal health department within your practice, or maybe you're a pediatric group and you say, any patient that has asthma and has an encounter around asthma, we want to send it to Martha down the road because she's really good with asthma patients and she knows them all. So these are the different smart alerts we can set up to help your organization kind of cut through some of the white noise that might be overload of all the different alerts coming in for things that maybe aren't as important as some of the other alerts, i.e. a 90-year-old with a heart attack might be more important than, a 25-year-old who has a cut on the finger. So hopefully smart alerts, it was a high level overview, but kind of piqued some folks' interest. Again, it's really good for organizations that have specific departments already set up in their ACO group or their health plan or their provider group to focus in on some of these things. I would not recommend setting a smart alert up and just assuming it's going to work. You need to have a case manager who's focused in on one of these particular things to really make sure they're paying attention to it, because otherwise the smart alerts are just like white noise because they come mixed in with everything else, and you really don't have someone who's able to take charge and really monitor and manage those alerts specifically. All right, next slide. I think we're winding down here. Yes. So I'm not going to read over all this stuff, but just a couple high-level things to highlight the benefit of the Florida HIE service and some of the things that we've seen, from improved clinical quality measures and reporting to increase and transition care revenue, and 30 to 50% reduction in hospital readmissions. These are all things that I think all entity types, whether you're an ACO, a health plan, or provider, can see benefit in. The improved management of chronic conditions, that from a health plan right there, hey, let's get them in a chronic condition program to prevent and give them the treatment and things they need to make sure that they hopefully can beat this, or at least manage this chronic condition, versus going to the ER every other day. Anyone in a value-based care contract, I think the clinical quality measures, performance reporting, all this stuff is really important to those entity types. And we want to make sure that we continue to provide those clinical quality measures, and ENS is a great way to do it, especially starting off knowing hey, my patient was in the ER for this particular thing, and that's going to impact my clinical quality measures. I want to make sure I get that patient out of the ER and get them the treatment they need to avoid them going to the ER again. So yeah, some of the bottom line results of ENS and some of the benefits. I think the Florida HIE has done a great job with this and providing some really good ADT data and quality data that really helps meet some of these results. So, all right, next slide. I think we're wrapping it up here. Yes. So I think my parting words would be before we get into some questions. My name is Brian Smart. I am the director of the Florida HIE. I've been working here for about 7 years now, and Aka and Pam King and Jamie, everyone over there has done a great job continuously driving for better quality, better data, and really driving the value of ENS. And hopefully with this education session, you guys can see that there's a lot more of value versus just knowing where your patients are and when they have an encounter. There's so much more that you can do this with data. There's so much more that you can do to treatment and the care coordination of the patients, and really showing that the quality of your patients is important to you as an organization, and how ADTs and ENS can support that. So thank you all so much for the time. And Jamie, I think we got 20 more minutes to hit me with some questions here.
Awesome. That was very informative, Brian. Thank you. Pam, I am gonna, Meredith, ask you if you guys, what the questions are in the question box.
Sure. Starting out, we have, how do you become a subscriber?
Yes, great. So there are, I don't know if we can send some links here, but there is a Florida HIE website that has information on ENS. And within that website, there is an ENS agreement and an onboarding checklist. You could review that agreement. It's a multi-party agreement, so there really isn't room for edits and changes from your legal team. But you can review that agreement, make sure you're a licensed entity, you have a direct treatment relationship with the patient, and you acquire consent from your patients. You sign that agreement denoting all that, and then after that, you send it to us. We'll reach out to you and help you complete the onboarding checklist. And usually within about 3 weeks, you're subscribed. Again, if you're an ACO registered by CMS, you can subscribe. And if you are a data contributor, like an acute care, skilled nursing, home health, hospice, you can subscribe as well. And of course, health plans can subscribe as well in the state. And Jamie, I don't know if we're able to send that link, but I can pull it up and provide it in the chat if you'd like. If that's easy.
I just provided it in the chat.
Okay, thank you.
All right, next up, what are the general costs to implement and cost per ADT or more as a customer or receiving the data of the HIE?
Yeah, so I think maybe I can provide you the link to the pricing sheet. The unique thing about the Florida HIE, and one thing I really love about it, is it is a flat cost. No matter the configuration you want, no matter whether real time, flat file, daily, whether you use the prompt portal, it does not matter. The cost that we provide you in this link, that is all based on your patients. That's how you get charged. So if you subscribe to 5,000 patients, you're going to get billed for 5,000 patients. And it's per member per year invoicing, and then we bill quarterly. So hypothetically, if your charge is $5,000 a year, we bill you $250 or $2,500 every single quarter, and it's based on your patient roster that you submit. So we look at the patient roster you submitted to us, and then that's what we're going to bill you on. And I'll provide the link to the pricing information in there. There are different pricing tiers based on the entity type you are, whether you're a provider group, an ACO, health plan.
Okay, thank you. Will the presentation be available after you finish?
Yes, I believe it's recorded, and I think they're going to send it out after this, probably in a few days, because I know the recording's got to get processed and then the link's got to get posted, but I'm pretty sure that happens, right, Jamie?
Yes, that is correct.
Is it necessary to subscribe to the Florida HIE through PCC if the organization receives such information through its EMR via payer data, including encounters, ADT notifications?
If I think I understand the question, no. The point click care organization is the EMR for skilled nursing facilities. Florida HIE manages ADT data and the flow of ADT data. So you don't need to be a point click care customer or be a skilled nursing facility to subscribe. The Florida HIE almost is separate from point click care, but some of the point click care data obviously flows into the Florida HIE. That's where we have a little over 200 skilled nursing facilities that are connected and contributing data to the Florida HIE.
Brian, this is Pam. I think the question was more, is there a requirement for subscribers to subscribe? I think. Adam, is that what you're asking? If you can type in yes or no, that'd be great.
Yeah, I know to that point, Pam, yet no, there's no requirement for a organization to subscribe to the Florida HIE. There is a requirement for acute care facilities that are in the low-income pool Medicaid funding to contribute data to the Florida HIE.
Okay. How can HIE help small ALF limited mental facilities, or how can we benefit, or how can they benefit from HIE?
Yeah, I mean, we have quite a few entity types like that are subscribed. I think right off the bat, just having awareness for your patients, where they're going, and what happens to them. An example is we've got a couple entities that are subscribed, and they're rather large, and they say at night there could be an ambulance that's called to one of their locations, and they weren't aware of it until 6, 7, 8 o'clock the next day. But being able to understand what that encounter looked like, what the diagnosis was, where that patient's moving around the hospital is really helpful for them. Yeah, I'd love if you have questions or you want to dig into that a little more, feel free to email myself or anyone with ACA, and we can set up a call and really dive into the specific use case that you think might be more beneficial to you. But yeah, right off the bat, just understanding where your patients are, what happens to them. I know we've got some home health organizations that are subscribed as well because they have limited access and understanding to what happens to their patients when they're not directly being treated by them.
I think a follow-up to that was, we take care of 28 limited mental with schizophrenia residents. How can we help with this program?
Yeah, I mean, the number there is relatively small, so maybe you already have a really good understanding when one of those patients goes into an acute setting for an ER encounter, and you may have someone on call on staff that has direct access to that patient during their treatment. So I don't know if ENS is really going to benefit you. I mean, it seems like such a small patient population. It may not really be overly helpful because it seems like you guys would have really good pulse and thumb on those patients, especially when they go to an ER for something like that. So yeah, maybe not overly helpful, but definitely something that I'm happy to talk more about if you think there may be some benefits to your organization.
Thank you. We don't have any more questions coming in right away.
A couple things to just everyone. The link I provided for the cost, I think, really shows that the commitment ACA has to wanting ENS data to be prevalent across the entire state for every subscriber, every entity type to obtain this data, because it improves the quality of care for Floridians across the entire state. And even if you can, especially if you're a medium to small size provider, I mean, if you think that even if you can call one patient and check on one patient after their discharge and make sure they don't need help, or make sure there isn't something you can do to kind of make sure they don't go in the ER again, to me, that's a win. And it lowers the cost for healthcare overall, and especially from a Medicare and Medicaid space. This is a good solution. It's an easy solution. We can stand it up and get most organizations live within 3 weeks. And it really doesn't take a heavy lift from your organization. There isn't like a ton of reporting that ACA is required, and they're going to, you know, be checking in on you. It really is for your benefit and how you feel like as an organization you can leverage this data to the best of your ability, the best of your patient's ability. And it's not something you sign on for that you're required to subscribe for 3 or 4 years. You know, we have some entities that do it and start out really small, and then they grow their patient population over the years because they understand the benefit and they see the value. Some do the other thing. They start really big and then they hone in and say, we actually only want this small group of our patient population because these seem to be the ones that continuously go in the ER and have, you know, chronic conditions and things we want to really track and monitor. So we at the Florida HIE can work with your entity and ask those questions and understand how we're really going to get value out of this service. We're not looking to push. There's, again, the pricing is on the website and there's no upsell. Like, we're not looking to push and sell you something else down the road. We just really want everyone to subscribe to this because I think it helps patients, it helps providers and ACOs understand what's happening with the patient, because you cannot be tracking them 24/7 and understanding when they have an encounter and why that encounter occurred and what encounter was important versus maybe what wasn't. I think that's really helpful for all people in the healthcare space, especially in Florida. And the Florida HIE and ACA does it really well. So. Pam, Jamie, are there any questions from your side or anything you guys want to chime in about?
You have answered all of my questions. Pam, do you have anything?
I think we're good.
Great. Well, I'll just say as a parting, thank you all so much for taking the time. We really appreciate the opportunity to speak to everyone, and I'll turn it over to Jamie. She might have similar, she might echo a similar tone, but thank you all very much.
Yes, thank you all for attending, especially for this new girl here at ACA. So I was a little nervous, but thank you all for joining. We appreciate it, and I can't wait till next month. I hope everybody has a great day.
Hi, everyone.